Hi everyone, I'm Mabel Toribio, and today I'll be presenting on reduced cardiac strain among women with HIV as it relates to inflammatory monocyte activation. As a way of background, women with HIV have an increased risk of heart failure and worse heart failure outcomes. Increased inflammation and immune activation, in turn, are thought to contribute to this heightened heart failure risk. We can assess various parameters of heart structure and function using advanced cardiovascular magnetic resonancy imaging. This particular type of imaging allows us to quantify cardiac strain. Cardiac strain refers to the deformation of the heart muscle wall as it contracts, and we could quantify cardiac strain by measuring the parameter global longitudinal strain. A representative image of how we do this using cardiac MRI is shown on this slide. This parameter is important because reduced global longitudinal strain has been shown to predict regression to heart failure as well as heart failure outcomes. We applied advanced cardiovascular magnetic resonancy imaging to answer the following questions. Number one, what is the difference in cardiac strain among women with versus without HIV? And number two, among women with HIV, what is the relationship between cardiac strain and heart function and structure, as well as the relationship between cardiac strain and inflammation and immune activation? In order to answer these questions, we performed a prospective cross-sectional study where we enrolled 20 women with and 14 women without HIV. These women underwent detailed immune phenotyping as well as cardiovascular magnetic resonancy imaging and magnetic resonancy spectroscopy as well. In here, we included women between the ages of 40 to 75, and for women with HIV, we required them to be stably on antiretroviral therapy. We then excluded women with a history of heart disease or diabetes. We also excluded women with current or recent use of medications that would be expected to potentially affect our study results. Here are the baseline demographic data of our study population. The mean age of our study participants was in the early 50s and relatively similar between groups. Their 10-year ASCVD risk score or cardiovascular disease risk score was also relatively similar between groups and relatively low. The mean duration since HIV diagnosis was approximately 19 years, and the median duration of antiretroviral therapy use was approximately 18 years. And then lastly, the median HIV viral load was 19 years, which is consistent with viral suppression. With respect to our primary endpoint, we found that women with HIV had reduced cardiac strain compared to women without HIV. And these results are demonstrated in the graph below. Here you'll see that the mean global longitudinal strain of women with HIV was approximately minus 19% versus approximately minus 23% among women without HIV. And here the less negative number is indicative of reduced cardiac strain. We also performed additional analyses where we controlled for traditional cardiovascular or heart disease risk factors and found that HIV status remained as an independent predictor of cardiac strain among our study cohort. We also then looked at the relationship between cardiac strain and heart function and structure, and found that among the whole group, but not among the subgroups, there was select indices of cardiac structure and function that related to cardiac strain. And in particular, we found a significant relationship between cardiac strain and left ventricular ejection fraction, which is a measure of systolic function. We also found a relationship between cardiac strain and a measure of diastolic heart function, that is left atrial passive ejection fraction. And lastly, we also found a relationship between cardiac strain and left ventricular mass index, which is a measure of heart structure or cardiac structure. Now here are the baseline immune data of our study cohort, and we here found that women with HIV had higher levels of select markers of monocyte activation. We did not, however, find any significant between-group differences in the percent or absolute number of the three monocyte subpopulations shown here. We did, however, find that among women with HIV, there was a higher degree of expression of the marker HLA-DR on the surface of CD14 positive and CD16 positive monocytes. This group of monocytes are inflammatory monocytes because of their pro-inflammatory cytokine signature. That is, when they're stimulated, they release pro-inflammatory cytokines or molecules. And further, HLA-DR is a cell surface marker that is a marker of immune activation. And so this higher degree of expression of HLA-DR on inflammatory monocytes among women with HIV is reflective of higher inflammatory monocyte activation in this patient population. We then went on to examine the relationship between cardiac strain and the immune parameters which differed between groups. And here we found that inflammatory monocyte activation related to cardiac strain among the women with HIV, and this relationship, however, was not found among the women without HIV. We then went on to perform additional analyses where we controlled for the HIV-specific parameters of CD4 T cell count as well as HIV viral load, and found that the degree or the level expression of HLA-DR on inflammatory monocytes remained an independent predictor of cardiac strain among women with HIV. So just to conclude, in our study, we found that women with HIV had reduced cardiac strain compared to women without HIV. We also found an important relationship between inflammatory monocyte activation and reduced cardiac strain among women with HIV, and this relationship was not found among the women without HIV. What remains to be determined in future studies is whether or not inflammatory monocyte activation is a driver of reduced cardiac strain among women with HIV, and further, whether or not targeting or inhibiting inflammatory monocyte activation could have effects to prevent progression to heart failure or heart failure outcomes among women with HIV. With that, I'd like to thank our study participants as well as our study team, including the principal investigators, Dr. Markella Zani and Dr. Thomas Nealon. I also like to thank the Center for AIDS Research at Harvard University for funding this study. And lastly, I'd like to thank the audience for your attention. Thank you so much.